Hello, everyone. I can see we've gone up to 27. So, hi, my name is Retesh. I'm an interventional cardiology reg at Bart's Heart Center in London. I may have worked with some of you. If you have worked with me, then I hope it was a pleasant experience. Otherwise, I sympathize. I'm going to be talking a little bit about murmurs for MRCP. Because it's the awful world we live in now. I've put in my Twitter handle. I do actually respond to messages. So if you want to message me something on there, feel free. I've also put in my Instagram for the medical finals Instagram thing that I ran, but I'm still relatively active. At least I keep it open now and then to have a look at it. Now, the reason we're doing this is because BitePACES, of which I'm a member, are running a PACES course. This is the first time we've run a PACES course before. I'm running it myself. I'm organizing it myself. PACES and PACES teaching is an actual passion project of mine. And anyone who actually knows me knows how seriously committed I am to it. I've done a lot of PACES teaching before. I've taught on all the other courses. I know there's the other names out there, which we don't need to mention. But we feel like this could be done better. And that's why we wanted to try and do it better. The very first PACES course I'm running is going to be a one-day crash course. I focused on neurology and brief clinical consultations, i.e. Station 5, because I think those are the two that everyone gets a bit worried about. Now, everyone knows brief clinical consultations isn't like the old school Station 5, where it was endocrine, ophthalmology, neurology, rheumatology, dermatology, etc. But because it is quite variable, and those particular specialities are things that medical SHOs often struggle with. Certainly, I'll put my hand up and say, I struggle with these and I was most worried about them. If we just step back and think about it, doing a cardiac exam, a respiratory exam, etc., I would argue are relatively simpler because we've all done them to death many, many times. But knowing how to handle an endocrine patient, a rheumatology patient, unless you've done that job, can be a little bit trickier. I wanted to focus on these two stations because they cause the most consternation, and I wanted to try and do it well. How is this different from every other PACES course? It's one-to-one patient instructor. I won't allow more than 2 candidates at a bedside, so you and one other SHO. And that, I think, is the biggest difference, because I think, and I've taught on a lot of these courses, I went to every single one when I did my MRCP. The courses can get a little bit like a factory floor. It's incredibly busy, and it can be a bit crowded now and then. Not always, but it can be. And the other thing is, having an instructor per bedside means you don't have to kind of miss out on every sign. I'd like you guys to actually spend good time with each patient and be properly taught effectively one-on-one with one other person there, because at least that way you can go around with your study partner. And that's what I wanted to commit to. The other thing I've done is I've made it so that if you did fail either of these stations, touch wood, you probably won't, but if you did, you could come back to this course entirely for free. And that's something that I wanted to insist on, because I'm pretty proud of what we're going to have here. I've gone around and literally handpicked the best instructors I could find, the best clinical teachers I could find, and it's a very, very good quality group who's there, and they are all, frankly, probably better than me, to be honest. But I am very proud of the group we've got and the course we're going to run. If you go there, you will find the PACES course, that QR code. If you go there, you'll find a Telegram channel, which we're setting up still, and I'm going to put free PACES materials on there, maybe bits and pieces of teaching that I find interesting. Do join both. Well, join the Telegram channel, certainly. It's entirely free. And regardless of whether you come to us or not, and I certainly hope you will, I hope you'll get some use out of the Telegram channel, which is going to have some resources on there. Now, there is, of course, a discount code, Early Bird. If you use that, you'll get 20% off, and the prices look like that. A single ticket will be $319. 2 tickets, i.e. you and a study partner coming together, and on the course date, if you are coming with someone, you can stick with them. So you two, because you study together, can go around as a pair and see all the teaching together. You don't have to be split up.
Retesh, just sorry, very quick. You're not screen sharing at the moment.
Oh, I did ask if you could see my screen. Sorry, I was screen sharing. Can you see my screen now?
Yes.
Okay, well, there's not much miss. You missed that slide, but it's not that exciting. Here, this is the PACES course. That's the QR code for, let me put away my face. There we go. That's the QR code for the PACES course website. That's the QR code for the Telegram channel. Why don't I leave that up as I chat? You can go there and get all of that information I was talking about. I hope I've been relatively clear otherwise. The discount code to get 20% off is early bird. It will allow you to get 2 tickets for $559 or a single ticket for $319. The reason we are costing for the course is because it's the only way to make it sustainable, to make sure we get the best teachers and pay for all the patients to come and have a good space to teach in. We're running this at Bart's Heart Center in London, and that location is right in zone 1. So there are like 3 stations within walking distance of there, one quite literally a minute's walk from there. So you should be able to go and get there relatively easily. I hope that'll make coming to the course a bit easier. This discount code, because we do need to at least try and break even, this discount code can be used 30 times max, or it will expire by the 30th of September, whichever comes first. I hope that's reasonable. I'll put up this exact same slide at the end, but I do want to get on to murmurs and crack on. I thought I'd start with something that is relatively straightforward, at least to me, and is a bit of a pleasure for me to teach. Okay, what I'm going to cover today are murmurs, heart sounds, and splitting of the heart sounds. But anyone who actually knows me and has been taught by me knows that's just not true, because what I'll end up doing is going off on tangents and teaching you all about some bits of clinical cardiology, which I hope are, well, they're interesting to me. They may not be interesting to anyone else. They're kind of interesting to me. Okay, this is how you listen for a murmur. With the stethoscope, don't press too hard, but make good contact. It's it's a real skill of how much pressure to put with the stethoscope on the skin. I don't want to dwell on it too much, but if you press too hard with the bell of the stethoscope, it will become like a diaphragm. And if you press too hard with the diaphragm, you will definitely lose some of the higher pitch sounds in particular. Aortic regurg basically disappears if you press too hard. You have to go quite gentle, but make good contact with the skin. You don't want that stethoscope to be loose on the skin so it actually moves against the skin. You want it to actually make good contact. So as the patient moves, if they're moving, your stethoscope moves with them, but not so hard that you basically obliterate any high-pitched, subtle sounds. The low-pitched sounds tend to hang around, but if you press too hard, it'll all become like a diaphragm and disappear anyway. So don't press too hard. That's one thing I'll give you some advice on. I'll tell you what, the best way to get good at using a stethoscope and listening for murmurs, and I know it sounds stupid, is just to listen on yourself and see the difference that happens when you press too hard. That is a real skill of how much pressure to use with your fingertips. If there's hair there, it really doesn't help. Try and go for a bit of skin if you can with relative lack of hair. If you can move some hair out of the way, that'll help. But hair certainly makes listening for murmurs a lot harder. You want reasonable contact with the skin without anything in the way. And that, which means, by the way, never ever listen over a t-shirt, because that's not listening. You might as well just listen from across the room. It's just pointless what you're doing. Listening over the t-shirt is for people who aren't really listening for nuance. So respiratory listening you can do because you're listening for vesicular heart sounds or absence of breath sounds, etc. But heart murmurs, there's no way you'll hear anything through a t-shirt. So if you see anyone doing it in real life, they're basically making up anything they hear. It's probably impossible to hear something unless it is a stonking great ejection systolic murmur. I kind of don't understand why anyone would listen to the heart at all while the patient's breathing, because it makes no sense to me. There is so much additional respiratory movement. The chest wall is moving, the patient's moving, they're filling their lungs with air and out of air. All of that stuff is going to get between you and the heart sound. So if you're listening to the heart, you should be asking the patient to hold their breath. End expiration or end inspiration, depending on where you're listening for. Lex rin is the mnemonic that goes with this. So left-sided sound should be heard in expiration, right-sided in inspiration. There's no real point listening unless the patient's breath is held. If you do listen like that, it's very obvious that you've never done a cardiology job. So if you are wanting to look super slick, do not ever listen to anyone's chest for murmurs while they're breathing. I mean, you're just making your life so much harder, which is completely unnecessary. When you're listening, I want you to try and be active about it. Now, I know that sounds a little bit like Jedi Yoda talk, but what I really mean is when you're listening, really, really think before you put that stethoscope on the chest, what should be there. You're listening for heart sound 1, heart sound 2, and then anything extra. So when you're listening, I want you to think before the stethoscope goes on, okay, it should be lub dub. Is there a lub? Yes or no? Is there a dub? Yes or no? Does lub sound kind of right? Does dub sound kind of right? Okay, that's covered. Now, can I hear the other things? And that's where my next point comes in. Never listen blind. Putting a stethoscope on a chest and being like, okay, let's just see what I hear, is not how a cardiologist listens to a heart. The way we listen to a heart and the way you should be listening to a heart is you put your stethoscope on there and you think, okay, is lub and dub there? And then there are only 3 or 4 patterns, and I'm going to go over them with you today that you need to know. There's, and there's. Can I hear any of these 3 patterns? Because that's basically 99% of murmurs covered. All I'm doing when my stethoscope is there, as I'm thinking, right, lub, dub, and then I'd run through my 3 patterns in my head, and I'll go over them again later. Can I hear any of those 3? And if you do that, you will pick up the vast majority of murmurs that you could pick up in an acute medical take, and you'll blow away anyone who actually uses an echocardiogram to look for murmurs. And that's how you'll be, frankly, a better doctor. I know we shouldn't get I mean, I am still a little bit romantic about the idea that clinical medicine is important. I know we have echoes now, and cardiologists never use stethoscopes anymore. But any good medic with the stethoscope is just as good as anyone with an echocardiogram. It really is the same. You just need to know how to use it, and that's kind of the point of the MRCP. Okay, this is how you present a murmur to an examiner. Because an examiner can immediately tell your experience level when you present a murmur and present it badly and fumble over the words. First of all, always time your murmurs. Even whether you're using the timing or not, I don't care, but you should time them. You should time them with a central pulse. So you time them typically with the carotid. You can go brachial, that's perfectly reasonable, but it needs to be with a central pulse. So carotid's fine. There's this whole business people get into, oh, you shouldn't use the thumb or because it looks aggressive or whatever. That's nonsense. Just time it with a central pulse. If you want to be very old school about it, theoretically, you should time, theoretically, in the old school, I'm talking 18th century textbooks, you time it with your fingertips, not your thumb, because theoretically the thumb has a pulse. It's all BS. You can time with whatever and you won't fail the exam because of this, but do time for the murmur. You'll fail if you don't time the murmur. Always talk about whether the murmur is louder in inspiration or expiration. That is a key cardiac clinical sign. And if you don't mention it, you kind of really, I mean, I think it's a pass-fail kind of thing. That's really basic clinical medicine that everyone should just be doing. You should talk about radiation even if there isn't any radiation, even if it's just to say there was no radiation or I couldn't detect any radiation. I prefer, instead of saying things like there was no radiation, I do prefer phraseology like I couldn't detect radiation, because it leaves you the little nuance that you're telling the examiner, I don't want to be arrogant, there may be radiation, I just couldn't pick it up. But the way you say it in a confident way is, I couldn't detect any radiation. And that sounds just, sounds a little bit nicer to the ears to an old school boss. Always tell the examiner that you could hear heart sounds 1 or 2, or at least comment on them. Heart sounds 1 and 2 are present, and etc., etc. The pro people like to give a grade. I personally, at least the impression is that the pro people like to give a grade. I personally don't really think a grade is helpful. Here's my rule. If you can hear a murmur, or if I can hear a murmur with my stethoscope, it's probably at least grade 3. The point of giving the grade is not actually clinically relevant. The grade of the murmur is completely irrelevant to the clinical severity of the lesion. It really doesn't matter. The most severe AS murmurs don't exist, because in very severe AS, you will lose the murmur. So the severity of the sound, the harshness of the sound, the loudness of the sound is kind of irrelevant. Lengths of murmurs matter, but the loudness does not matter. I personally prefer something like this. This is a little spiel that I wrote in medical school, and I memorized it. It served me well for MRCP as well. This is how I would present a murmur, as an example. There is an ejection systolic murmur of at least grade 3 severity, heard best in held expiration over the aortic valve, with the patient sitting forward, radiating to the carotids. Notice the use of the phrase of at least grade 3 severity. It's because I'm telling the examiner I can hear it. Now we can quibble about what is 3 and 4, and I know people will say, well, 4 is a palpable thrill, etc., etc. All of that stuff is clinically irrelevant. And to the MRCP station, grading is really not a pass-fail thing. If you can't grade a murmur, but you present the perfect AS, they are not going to fail you. You just have to be practical about this. While you spend this time learning the 5 or 6 grades of like murmur severity, you're wasting energy and brain space that could go into learning much more useful things that are relevant to clinical medicine. You're here to become a registrar, not to regurgitate random tables which are clinically relevant. So I just think grading is stupid. And if you want to do the dance, you say at least grade 3 severity and crack on. No one's going to stop you and quibble with you about that. Remember that a thrill is a palpable murmur. So that question has come up before in MRCP stations. It may come up again. How do you define a thrill? A thrill is just a palpable murmur. That's what it is. Remember your other heart sounds. The third heart sound is, or S3, is rapid ventricular filling. It's caused by rapid ventricular filling. It may be a normal variant, but of course you can also get this in mitral regurgitation. So young, healthy people with nice compliant left ventricles, when they go for a run or do some exercise, they can get an S3 sound just from rapid ventricular filling. And if you have mitral regurgitation and the leaflets aren't working very well and they're leaking quite freely, that's rapid ventricular filling you can get from that. Therefore, with MR, you can get an S3 as well. S4 is always pathological. So S3 can be a normal variant. S4 is always pathological. S4 is caused by the squeezing of the atrium to fill a very thickened, non-compliant left ventricle. And it is always pathological, always abnormal. The only 2 causes of that you need to know, there are others, of course, are HOCM and aortic stenosis. Guys, I can see Q&As coming in. I don't have it open on my screen. Can I take Q&As at the end if that's okay? Just because my screen real estate is going to prevent me from doing that. Okay. Let's talk about our different murmurs then, because that's what we really came here for, is to try and understand the different patterns of murmurs and hopefully walk away feeling a little more confident about them. Aortic stenosis patients, remember when I said, okay, let's take a half step back. Remember when I said, I don't want you to listen blind. I want you to try and predict, if you can, what murmur is likely to be there. You can often, in fact, I would argue in every single case, if there is a clinically relevant murmur, you'll be able to see signs at the bedside that tell you what the diagnosis is long before you use the stethoscope. You can normally pick up all of these things at the bedside. Aortic stenosis patients typically have a slow rising pulse, right? It's a low volume, slow rising pulse. It's really hard to feel. That's what low volume actually means, that the volume of blood underneath your fingertips, when you feel it, feel the pulse, is very small. It's very, very small volume, which means you can barely palpate the carotid. Slow rising is a bit more tricky. Slow rising means that it peaks a bit later than you would expect. Now, you can only really see that properly if you had an arterial line in the patient and looked at the arterial trace, which you don't have, obviously, unless it's a CCU or an intensive care unit. If what this is suggesting is if your hands get good enough with enough time, you should be able to pick up slow rising with your fingertips. One other thing to remember is some people can, most people don't have this skill anymore. It's also impossible to feel a slow rising pulse when the patient's tachycardic, because what you're feeling for is a 10, 20 millisecond delay in peaking of the aortic impulse. If you feel your own carotid pulse, it just goes bop, 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 hopefully. If you were to draw it up, it would be like this. With someone who has aortic stenosis, it would just, the impulse peak would come a bit late. That little difference is very hard to feel with your fingertips. And in the era of arterial lines frequently being used, you don't need it. And we have echocardiograms and other things. So it's not actually clinically super useful. And it's also impossible to detect when they're going fast. So I wouldn't worry too much about being able to feel slow rising. I would worry if you can't feel low volume. Low volume just means I can barely feel that pulse. That's all that means. Patients with AS also have a narrow pulse pressure and sometimes a very big, obvious, the correct word is a hyperdynamic heaving apex beat. And that's because of left ventricular hypertrophy. But the key sound that you hear with AS is the very first thing you would notice is loss of the second heart sound. S2 typically disappears in these patients. And that is also a key sign of severity in AS. In fact, before the echo guidelines kind of came into their own and everyone had access to an echocardiogram, the loss of S2 in someone with AS was considered a key marker that this patient would need surgery. That's how important loss of S2 is considered to be. So loss of S2 is a key marker of severity, and that's easy to pick up. All you're listening for is lub and then no dub after that. The loss of S2 in anyone with AS should worry you because that's probably severe or critical AS. It's normally very severe. The murmur sounds like this. Oops, it should just play, but I'll play it. I don't know how well that projects. I'm going to dwell on this for a second because this is really, really key. When I'm going to play that again, because effectively you were listening blind, you didn't know what to look for right now. What you're listening for is lub and dub, and in between lub and dub, you're hearing for a sound that goes up then down. The other name for an ejection systolic murmur is a crescendo decrescendo murmur. So it goes, well, the way you're looking at me, I presume it'll go like this on your screen. It goes up then down. So it goes, and that sound, that intensity that rises then falls, is a key sign of aortic stenosis. It is completely different to mitral regurgitation, where the intensity stays the same. It just goes one pitch that does not really change throughout systole. An ejection systolic murmur goes up and down. There's actually a couple more nuances as to why it's called an ejection systolic murmur, but to be honest, for the sake of brevity and for the fact that you actually don't need to know it for MRCP, we don't need to discuss that here. If you decide to do cardiology as I say, prolonged and become a registrant, we can discuss what ejection systolic means versus hollow systolic, is they talk about actual ejection of blood coming out of the heart versus just systolic time. We can discuss that as a physiological curiosity at some other venue. But for the purposes of this, ejection systolic, crescendo decrescendo is the sound you're listening for. Now, the sound I'm about to play is actually severe AS because there is a lub, then you hear, and then no real dub. There should be a nice, crisp dub at the end of that sound. And the absence of that sound tells you this must be severe AS. So don't just immediately listen and think, oh, good, I hear a murmur. It sounds ejection systolic. I'll pause. I've got the diagnosis. No. Then engage your brains and think, okay, at the end of that sound, is there a dub? It might be there, and 1 or 2 beats I can just about hear it. It's very quiet though, and that's probably a sign of severity. When it completely disappears, it's very severe. Biggest problem with this is the faster the patient's heart rate goes, the harder it becomes to hear. Another reason you should really calm your patient down before you start listening for murmurs. There's no point if they're freaking out and they're caffeinated and stressed out by the candidate who's also feeling stressed. The more relaxed they are, the slower they'll be, and the more time you'll have to actually appreciate all the bits of the heart sound. Some of this comes with practice, and some of this just comes with a bit of luck. What if your patient had an ECG like this and that same sound? Well, then they would have one of the differential diagnoses for an ejection systolic murmur. They would have hypertrophic cardiomyopathy. Even watching this ECG, even though I picked it up and put it up for you just by Googling, it's making my hackles rise because this is hypertrophic obstructive cardiomyopathy almost certainly. This is probably a formal cardiomyopathy patient as opposed to just LVH from hypertension or something. When you see these QRS complexes overlapping like this, and particularly when they're very big in AVL, that's normally a good marker. This is not an ECG talk, but that overlapping of QRS complexes is always worrying. The first thing I would do is check that this isn't 20 millimeters per millivolt. Just make sure the calibration isn't exuberant. And if that's fine, then it's probably HOCM. HOCM patients, of course, have things like this. Now, this is an echocardiogram. You don't need to know echocardiograms, but you might as well see a couple of pictures. And this is the septum in the middle. This is the left ventricle. And you can see complete obliteration of the left ventricular cavity. This is the left atrium, and the aorta comes here. The reason these guys have a murmur, and the reason I put this echo up to show you, is because they cannot get blood out from the left ventricle into the aorta. I wanted to show you that the septum is in the way. So instead of having aortic stenosis, what these guys have is that their septum is actually obstructing flow out of that ventricle. What that means is, if I use a laser pointer, what that means is they're trying to get blood from here to here and occluding flow, they'll get turbulent flow. And that's why it's an ejection systolic murmur, because it's the same kind of thing as what would happen if this patient had aortic stenosis. That's why HOCM patients have that same murmur. It's because of this pathology. And now that you know that, you can kind of predict all the 10 different things that lead on from HOCM and why it's such an important diagnosis to get right. If you understand that piece of clinical medicine, it opens up all the doors to understanding HOCM and how you treat it. I'm not going to get into it today because frankly, the talk doesn't allow that much time to do it. This is meant to be a 20-minute, 25-minute talk. I'm definitely going to overrun. I know that. I've practiced it. But I just thought there's no way to teach murmurs without teaching a little bit of cardiology. HOCM patients have an ejection systolic murmur and a heaving apex beat because, well, look at that ventricle. It's going to be a big heaving, sustained impulse apex beat when you feel it because there's a lot of muscle there. They typically have a jerky pulse because as the blood comes out of here, this septum obliterates flow and then it comes back. So this pulse doesn't just go dub, dub, dub when you feel it. It feels like a little jerk, especially when it's obstructive, properly obstructive cardiomyopathy. And the double apical impulse for a similar reason, just a lot of muscle, and sometimes they have this jerky thing which you can feel. There's often, of course, you will know, and this is all from medical school, family history of sudden cardiac death. It's autosomal dominant. Interesting things for MRCP associated with Parkinson-White and Friedreich's ataxia. So it can come up, or can be aware that it may come up in a neurology station if it's relevant, which is, of course, relevant to your neurostations, right? The systolic anterior motion of the anterior mitral valve leaflet is what we look for on echo as the key sign. But I mean, this echo is pretty clear cut. And we're looking for SAM, systolic anterior motion of the anterior mitral valve leaflet, to make a diagnosis. And of course, we can do genetic testing as well. If you make that diagnosis, the family has to be referred for genetic testing at a cardiomyopathy clinic, which we can do. Differential diagnoses of ejection systolic murmurs includes any systolic murmur, but that's kind of anyone who's been trained by me should not be giving this answer because that's a cop-out answer. You can say it, but it's a little bit low rent, and I expect you guys to do better than that. So specific ejection systolic murmurs are HOCM. Typically, HOCM gets quieter on squatting. We tend not to teach so much dynamic auscultation, and it very, very rarely is expected to be known at MRCP. When we do expand the course, as I plan to do, and do cardiology proper, and maybe we can do a second webinar on this, we'll see how it goes, then we can talk about dynamic auscultation. It's actually pretty simple. No one ever does it in real life, but it is in the textbooks. Aortic sclerosis is in the older books as a differential for ejection systolic murmurs. The difference in sclerosis and stenosis is that this is scarring of the valve. Stenosis is narrowing of the valve. So it's actually narrowing of the valve area, and that's occluding blood flow. And because of that, in sclerosis patients, you don't get any changes to the apex beat or pulse, but you get the murmur because of turbulent blood flow. Whereas in stenosis, you get the pulse changing, so it's low volume, slow rising, and you get changes to the apex beat when the heart hypertrophies eventually. Aortic regurgitation is a different kettle of poisson. Typically, patients have a very, very big pulse at the carotid. There's a collapsing pulse there as well, which we're not talking pulses today, but if we do, I need to show you guys how to feel for a collapsing pulse. I have yet to meet an MRCP candidate who could feel for it correctly, to be honest. And typically AR patients have a wide pulse pressure, big apex beat. It's again, a big, large left ventricular impulse and a diastolic murmur. So typically it's an early diastolic murmur. Just trying to pause it. By the way, those two, the sound and that video are obviously not linked together. I just wanted to show you dancing carotids or Corrigan sign at the same time. It's the most obvious end of bed sign for significant aortic regurgitation there is. There's obviously a bunch of signs. This is probably the most useful one at the end of the beds. It's Corrigan sign, dancing carotids. The murmur, I'm going to play that again, but I want you to think about the pattern as I do. Because it's diastolic, it goes after the dub. So it's lub, dub, and then a sound afterwards. When we finish this talk, I want you to take your stethoscope out, and diastolic murmurs are tougher. That's why we need to just practice this. Listen to yourself. Listen to the aortic valve area or down near the sternal edge. That's the other place you can hear this murmur. Listen to yourself in held expiration, leaning forward. That's the best way to listen for an aortic valve murmur. What I want you to do is listen for lub, dub in that space in held expiration. Don't do it now. Listen to me for now, but afterwards, just try that out. And the reason I'm saying that is you will notice that after the dub in that spot where you're listening for the aortic valve really carefully, In yourselves, hopefully, there is no added sound. Lub, dub. Dub is a really sharp sound. There is nothing after that. There should be complete silence. That's normal. It should be lub, dub, lub, dub. In patients with aortic regurgitation, you are going to be listening for lub, dur, lub, dur. That slurring of the second heart sound, that is your early diastolic murmur associated with aortic regurgitation. Listen again to this patient as I play it, and listen for dub and the absence of silence after the second heart sound. That's what you're listening for. All right? Hopefully. Now, obviously, I picked really good sounds for this talk, at least the best ones I could find that weren't copyright hidden on Google. You know, aortic regurg and AS and all of the others, they come in different shapes and sizes. You can get more difficult murmurs than this, but typically if they're coming for a PACES exam, they will pick people with exemplary clinical signs. MS is different, tends to be female patients, and to be honest, it's very unlikely you'll see this at PACES anymore. It's now very, very unlikely. They tend to have low normal blood pressures, not particularly exciting stories, and a rumbling mid-diastolic murmur. Here, what you're listening for, because this murmur is in the later part of diastole, it's not early diastolic, it's mid to late diastolic. What you're listening for is a sound just before heart sound 1. So aortic regurg is early diastolic. It goes lub, dur, burr, lub, dur, just after number 2. What you're listening for with mitral stenosis is just before heart sound 1. It will go relub, dub, relub, dub, relub, dub. That's the sound you're listening for. Have a listen, try and find lub, dub, and then just listen. Can I hear anything before lub? Anything before lub means that it's mid to late diastolic. Anything after dub, immediately after dub, is early diastolic. And that's how you can time it. Obviously, you should be timing it with the carotid properly, but you can, in most patients, tell lub and dub apart. So you should be able to hear this. And of course, the red mitral facies, that's why I put that picture. He's also got a fourth heart sound. Okay, so this lady, or this murmur from whichever patient it's from, has got a relub dub, and actually there's a duralub dub. It's actually a fourth heart sound as well, which isn't that unusual. This patient's tachycardic, which makes it harder to hear. You will notice that lub is really loud. So there's a loud first heart sound, which is a key marker in mitral stenosis as well. You get this idea of a palpable first heart sound, a tapping apex beat, which, as I'm sure you're aware, tapping apex beat is pathognomonic basically for MS. It's an old phrase that they used to use in exams. And it just means, a tapping apex beat basically means MS. That's what the examiner is saying to you. So I would never use that phrase in an exam, because what you're telling the examiner is this is definitely MS. Whereas a loud first heart sound can be a couple of things. It's a very harsh first heart sound as well. It's very loud. So patients with MS can be an AF. So that's not a heart sound feature, but just be aware they can be an AF. Loud first heart sounds or tapping apex beat, as I've pointed out there, is a typical feature. They can have an opening snap. I got to say that's very, very difficult to hear. It's very hard to hear in practice. Sometimes examiners, certainly old school examiners, may ask, what's the benefit of hearing an opening snap, or what does that tell you, and how is that clinically useful? If you can hear an opening snap, which I'm not saying you can, but just be aware, the audibility of an opening snap tells you that the heart valve is pliable. That means the heart valve, if there's an opening snap, that means the heart valve is not very calcified and may be suitable for balloon valvuloplasty. Now, of course, contemporary practice, we don't use that. We use echocardiograms and cardiac CT and cardiac MRI. We use all sorts of other ways to image the valve, and 3D echocardiography and all sorts of fun and fancy things. the presence of an opening snap is a little bit of an ancient kind of curiosity from textbooks from the 50s and stuff. It's not something that actually is clinically that applicable anymore, but that's what it used to mean, that this is a pliable valve which can be used, which can be valvuloplastied. A question that might come up is, why is the first heart sound loud? And that's because the left atrial pressure is chronically increased in patients with mitral stenosis. And because that left atrial pressure is increased, because the mitral valve is tight, blood pools up in the left atrium. And because that pressure in that atrium is so high all the time, to actually open that valve, it means that you need to have a lot of pressure. Sorry, to actually snap that valve closed, you need to have a lot of pressure to overcome the left atrial pressure from the ventricle. So at the point when it snaps shut, the pressure in the ventricle is pretty damn high. And that means when it snaps shut, it does it really, really loudly. And that's why S1 tends to be really loud. And it also, technically, the presence of a loud first heart sound tells you that the leaflets are able to move, which means that they're probably not calcified. In contemporary practice, most mitral stenosis we see now is very calcified. So S1 being loud, we may miss out on, we may not see it. There is one other feature which I haven't put on this slide, which maybe I should, is that mitral stenosis tends to give you something called pre-systolic accentuation. Just before S1, you have that murmur getting louder. So it goes, instead of going r-lub-dub, it goes r-lub-dub, r-lub-dub, and it gets louder. And that's because of atrial contraction just at the end of diastole. Now, for that to happen, the patient cannot be in AF, obviously. The vast majority of patients with mitral problems, stenosis or regurgitation, will be in AF. If they have any significant amount of mitral stenosis or mitral regurgitation, their left atrium will start ballooning out. And as soon as that happens, they go into AF. And that's why you may lose that. Pre-systolic accentuation requires, obviously, atrial contraction to be in synchrony. And that will not be possible if the patient is in AF. The other thing that happens with MS patients is that they tend to have high pulmonary pressures, and they can have a loud and palpable pulmonary component of the second heart sound. So loud P2 is something you might find. What do I mean by loud P2, by the way? You must have read that before and been like, what does loud P2 versus a normal P2 actually mean? It's really simple. Take your stethoscope, listen to the aortic and pulmonary areas in yourselves, held expiration, held inspiration, respectively, and you will find that the aortic second heart sound is much louder than the pulmonary second heart sound. And that's normal. That's what it should be, because the pressure on the aortic side is larger. Loud P2 is when it's reversed, and the pulmonary component of the second heart sound, or P2, is louder than A2. That's the wrong way around. That tells you that the pulmonary pressure must be pretty damn high, and it's probably pulmonary hypertension. You can get these other murmurs from pulmonary hypertension, like pulmonary regurgitation, also called Graham-Steele murmur, and you can get a tricuspid regurg murmur. I've put in the, I was a little bit enthusiastic. I've put in some of the eponymous names. You don't need to know any of those eponymous names for MRCP, but just FYI. Differential diagnoses for a mid-diastolic murmur. Well, it could be one of these, if I can get my pen back to, I just go back to pen. Oops, now I'm drawing. How do I go back to pointer? Just one moment, automatic. I can't seem to get rid of the laser. Oh, there we go, just to click it, there you go. So that's a cardiac MRI of an atrial myxoma. That can be a differential diagnosis for a mid-diastolic murmur. So MS can do it. Austin-Flint murmur is a sign of a severe AR. And that is when you get a mid-diastolic murmur in aortic regurgitation. The reason you can get this is because of the regurgitating blood vibrating the anterior mitral valve leaflet on its way back into the ventricle through the aortic valve. And that vibration can sound like a mid-diastolic murmur. It's pretty rare, to be honest. And if the patient has that, they'll have an early diastolic murmur as well. But the presence of an Austin-Flint murmur would suggest severe aortic regurgitation. Tricuspid stenosis can do this as well, but of course it's on the right side, so the murmur will be louder on inspiration as opposed to expiration. So theoretically, you shouldn't be making that mistake, but there we go. TS is pretty rare. ASTs also give you a mid-diastolic murmur, which is an interesting one that people often forget. That's one of your differentials. ASTs can cause a mid-diastolic murmur. And of course, with myxoma, you look for the other signs, fever, clubbing, and the fact that they can embolize and cause strokes. Oops, there we go. Now, I wanted to include this just for completeness. Tricuspid regurgitation and what it looks like. You get big neck pulsations, peripheral edema, pulsatile hepatomegaly, pansystolic murmur. This is where I want to pause. You will find in clinical practice, once you start listening to enough people with TR, should that ever happen, that most people with tricuspid regurg don't have a murmur. And it's really simple why they don't. Because the echo will say moderate to severe TR, and you listen really hard and with a good quality stethoscope, and you're like, Ritesh said pansystolic murmur, I can't hear it. And the echo says moderate to severe TR, but I can't hear it. Here's the thing. The right-sided valve and the right-sided chambers, the atria and ventricle, the pressure there isn't really high enough to generate enough turbulent blood flow for you to be audibly able to hear a murmur, even when it's severe TR. Most TR is inaudible. It's completely inaudible. So you can't hear it at all. The only time you will be able to listen to TR and actually hear it through a stethoscope is when the patient has pulmonary hypertension. The audibility of tricuspid regurg basically requires that the pulmonary systolic pressure in the pulmonary artery is high. Why is that all a bit of physiology relevant to you? Well, does anyone listening to me want to do respiratory medicine? Okay, the number one killer for chronic COPD patients, chronic lung fibrosis patients, chronic bronchiectasis, anyone who doesn't die in those patient groups from cancer or lung infection or respiratory failure will die from a cardiovascular cause. It's one of the number one causes of death in that group. And the presence of an audible TR murmur in those patients tells you that their pulmonary artery systolic pressures are high, which means they have pulmonary hypertension, which means they probably shouldn't get onto a ventilator. I'm not saying it should be your life and death decision-making process, but it is a clinical sign that this patient probably has pulmonary hypertension and may not do so well on a ventilator and may never be able to get off that ventilator. Now, knowing that, and of course, you'll put years of clinical experience on top of that, may be able to help you on the front line when you see these patients and be able to listen and find the value in that murmur should it be audible, okay? So this is very, very important bit of physiology because it does portend and had direct implications for longevity and treatment planning and kind of seedings of care and things like that. Lots of things associated with tricuspid regurg, pulmonary hypertension is one of them, also endocarditis. Patients with Ebstein's anomaly can have apical displacement of the tricuspid valve, which is a congenital thing, and they have TR congenitally. Carcinoid syndrome is one of the commoner causes of right-sided valvular issues and can cause tricuspid regurg as well. Key findings in mitral regurgitation, AF, like I mentioned before, anything mitral can cause AF, dilated left ventricle, and therefore you tend to have a infralateral displacement of the apex. And they tend to have an S3 because of rapid ventricular filling. This is what it sounds like. What you should be noticing is that the pitch of sound does not change throughout systole. It is throughout systole. And this is where actually feeling the pulse will help because lub and dub are in there. And maybe it's better through my speakers than via Zoom for you. But I do recommend you Google for a mitral regurg sound later and just have a listen to it. By the way, all these sounds you should Google and listen 10, 15 times. The point of listening is to get used to that pattern. That pattern is what you're listening for. You know, no one's, I always tell people when they're learning murmurs, just consider this. If I asked you to sit down on a keyboard and play out Taylor Swift song, you probably couldn't do it, right? Most of you couldn't. But if I ask you to hum me the tune, you probably can because you are good at pattern recognition, but you're not so good at actually generating that sound from scratch. So actually, what you're listening for when you're listening for murmurs and learning these sounds is you're listening for the pattern. You need to learn the pattern. So again, a pitch that does not change. Okay. Now, I'm going to give you one final case because it's an important one, and it's important for you to see this. A young woman who's cyanotic and has this scar underneath in just the breast angle right there, just under the skin, and it's well hidden away. She's clubbed, she's cyanotic. These are the patients that typically have pulmonary hypertension and may have that tricuspid regurgitation murmur, okay? These are the typical patients. There are 4 things to remember in any cyanotic patient. You got to look for the clubbing. Look for the fact that they may be in AF. This is poorly taught, but they often are. They very, very often are in AF. They may have signs of right heart strain. They almost certainly will do if they're cyanotic. They probably have pulmonary hypertension. And if they didn't start with it, they will end up with it. Cyanosis will lead to it eventually anyway. They'll have parasternal heave, JVP, loud P2, all that stuff. And they may have a scar from previous congenital heart surgery. When you see a patient like this in a cardiac station, the tendency is to panic. You think, oh crap, I learned all about AS and now they're giving me a congenital cyanotic heart disease. And it's very, very tough. And I don't know what to do because, oh crap, what was the thing that happens with the tetralogy of Fallot and all of that kind of stuff? You just need to calm down. There's only two cardiac causes for a patient like this. They are cyanotic because they are mixing blood from left and right sides. Okay, so there's a shunt somewhere. Okay, so that's one differential. Now, obviously, a shunt has 50 differentials underneath it, but you're telling the examiner that you can divide this sensibly, right? There may be a shunt somewhere. That includes VST, AST, PDA. There's lots of different shunts, but there's a mixing of blood somewhere. Just think about it logically. Or this patient has pulmonary hypertension and therefore they have pulmonary vascular disease and oxygenation of blood is not possible through that diseased vasculature around the alveoli. That's the other thing it could be. Now that could be primary pulmonary hypertension is a thing, of course, can happen, right? Or it could be acquired. So they develop pulmonary hypertension from an old shunt that's just been there for a long time, caused pulmonary hypertension, right? Like a VSD or something. And they had reversal of the shunt and chronically high pressures, and they ended up with pulmonary vascular disease. So shunt is actually underneath both of these. A shunt can on its own make you cyanotic, but a small shunt may not make you cyanotic. Eventually, it'll cause pulmonary hypertension, and then it will make you cyanotic. Eisenmenger's is reversal of left-right shunt, of course, causes cyanosis. It's irreversible, and typically they'll have tricuspid regurg with a bit of pulsatile liver. You might be able to differentiate what's going on by the presence of a wide split of the second heart sound. You have to look for a scar to see if they have a previous correction of VSD scar somewhere. And the causes of Eisenmenger's, the top 3, VSD, AST, and PDA, I would expect you to know. The smaller print causes you probably don't need to know. With VSDs, this is the most common congenital heart lesion. And yes, you absolutely can get a VSD in the exam that's been uncorrected, especially if it's a small VSD, which is not causing a lot of mixing and no cyanosis. We can often just watch them for years. So VSDs don't always get closed. There are specific guidelines on this. You can just have a chronic VSD. And these ones will cause a pansystolic murmur at the tricuspid valve site. I will be a little bit bold here and actually say that if I hear a tricuspid regurg murmur at the tricuspid valve area, I personally actually think it's probably more likely to be a VSD than severe pulmonary hypertension. I mean, normally you can see if the guy's smiling at you and has no pedal edema and has excellent exercise tolerance, it's really unlikely that that guy clinically or lady clinically has severe pulmonary hypertension. They just don't look like that. Whereas if it's a smiling guy with that murmur, more likely to be a ventricular septal defect, because it's unlikely to be tricuspid regurgitation. Otherwise, they'd have pulmonary hypertension if I can hear it. If I can hear it, they have PH is the kind of rule of thumb. So if you can hear that murmur there, then you got to wonder if this man has a VSD or this patient has a VSD. VSDs will lead to left ventricular dilatation, therefore infralateral displacement of the apex. And remember, and you might see this in the MRCP books, a maladie de Roger is a very small defect and can give you a very loud murmur and normally doesn't need treatment. It just means small VSD. That's all maladie de Roger means. ASDs are pretty common. I mentioned they can cause a mid-diastolic murmur, and they can cause fixed splitting of the second heart sound. I'm going to get on to what splitting is at the end of this talk so you understand it. And I know splitting is something that always freaks people out because it's a tough thing, and it's not everyone learns it super well in med school, and it's something that I intend to go over properly. ASDs, the thing to remember is the risk of AF is high, so these patients may well be in atrial fibrillation, and that's why the stroke and all of the associated risks might be there. And of course, risks of paradoxical emboli to the right side, or from the right side to the left side. And indeed, you can get a risk of Eisenmenger's with this, which is why I put it into this section. Patent ductus arteriosus, very rare, very unlikely you'll see it. Just to be aware, it's a left to right shunt to begin with, and it can do an Eisenmenger's and flip around right to left. Classic history with PDAs is you get a differential cyanosis and clubbing. What that means is some of the patient toes are clubbed, but the fingers aren't. So it's a little bit differential, and there's the same with the cyanosis. That's the classic history. It's very unlikely you will see this in adult medicine. This is more for pediatrics, but obviously these patients may come to adult clinics, and it's just something to just give you an FYI to round out that knowledge. The continuous machinery-like murmur is the classic finding here. Obviously, I have to tell you, I don't think I've met anyone who had a PDA in MRCP. It is very rare. I've heard stories, but I've not actually met anyone, so I keep thinking it must be apocryphal. The continuous machinery-like murmur theoretically is best heard at the left infraclavicular area, and it's loudest in systole. It's throughout systole and diastole, and you can get a collapsing pulse with these patients. And of course, indomethacin promotes closure, but that's more for pediatrics. Now, we're going to get on to what I'm finishing this talk with, which is splitting of the second heart sound. I do apologize, I've run over. I knew I would, and I definitely have. Splitting of the second heart sound. I do think, obviously, you don't need to stay, by the way. I can't see who you are, and if you leave, no one's going to hold that against you. But if you want to understand splitting of the second heart sounds, this next bit lasts 5 minutes, and I will hopefully explain it well. Okay. This is what you need to do. Listen over the pulmonary area. Here's some rules of thumb. Normally, the aortic valve closes before the pulmonary valve. And the way you can remember that is alphabetically. A goes before P. So the aortic valve should close first. That's normal physiology. That's what should be happening in everyone. And it just closes a hair of a second, you know, like not obviously not like 3 seconds before, but just a little bit. The aortic valve typically closes before the pulmonary valve. That's what should be happening in normal physiology. It took me ages to do this drawing, so I hope you'll appreciate it. This is an animation of someone breathing, hence the lungs going bigger and smaller with inspiration, expiration. This is what's happening to your circulation at the same time. Here's another rule to remember. I said the first rule, A goes before P. Aortic valve closes before pulmonary valve, all right? The second rule, when you take a deep breath in, when you inspire, blood comes into the right atrium. That's those 2 arrows there are meant to be the SVC and the IVC. And the reason that's happening is when you take a deep breath in, you are having a negative intrathoracic pressure, because that's the only way air is going to fill the lungs. You have to make the pressure in the chest negative, i.e. low, and air rushes down the pressure gradient and into the chest. While you're doing that, you have also made the pressure in the heart or in the vasculature lower, and blood will come back any way that it typically does. And that will be SVC and IVC. So right atrial filling, and therefore right ventricular filling, increases when you take a deep breath in. That's another rule of thumb that you need to remember. Okay. I already told you that A closes before P. Okay. Let's say that A is represented by this red line and P is this blue line. The aortic valve closure is here, and in fact, I don't know if you can see my pen, so I'm just going to do this properly. Give me 1 moment. Let me just add a pointer or something to this. I sincerely hope you can see my laser pointer. The red line here is a representation of the aortic valve closure. The blue line is a representation of the pulmonary valve closure. That's what's happening. That animation. Let me pause and explain what I mean by that. Just put your hands in front of you right now and do this with me. Do this with me at home. I can't see you. You're not looking stupid to anyone, I promise. Aortic valve, pulmonary valve. When you take a deep breath in, just spread the hands out like you're breathing and it's part of your chest, right? Just go. At the end of you breathing in, you have a wider split of the second heart sound. This is the split of the second heart sound, your two hands, aortic and pulmonary. When you take a deep breath in, and when I say you, I mean any patient without cardiac pathology. Let's just say you means normal. When a patient without any pathology takes a deep breath in, the aortic and pulmonary valve closures are further apart. Why is that happening? Because when you take a deep breath in, you are filling the right side of the heart with more blood. Therefore, you are delaying pulmonary valve closure. I hope that makes sense. The easy way to remember that I came up with, and I hope you'll appreciate and enjoy, is if you just forget all of that physiology, just remember aortic, pulmonary. Okay, so in normal people, when I take a deep breath in, they are further apart, right? So splitting of the heart sound increases with inspiration in normal people. That is normal, okay? I want you to remember that forever. But if you want to learn the physiology and the reason and the vasculature, blah, 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 when you take a deep breath in, blood fills the right ventricle, it delays pulmonary valve closure, and that's why they're further apart in end inspiration, okay? And when you breathe out, the converse happens for the same reasons. Okay, cool. I've explained you're now 80% into splitting of the heart sounds. This will all make sense in a second. On inspiration, and here it is me explaining it, blood is being suctioned into the right atrium, which increases right atrium and therefore right ventricular filling, which delays pulmonary valve closure a bit, and therefore, since the aortic valve closes first, it increases the natural split of S2. That's normal physiology. Okay. This is what happens when you have a bigger than normal split, so a really wide split. A split can be wide because it's exaggeration normal physiology, so young, healthy people can have this, but you can delay pulmonary valve closure a bit more. If your patient has a right bundle branch block, right, on an ECG, and you can just go to the ward and find lots of people with a right bundle branch block, right? It's easy. Listen to them and listen for this. You will find that they have, at the end of taking a deep breath in, a really wide split of the second heart sound and much wider than normal. That's because their pulmonary valve closure is even slower because they have a right bundle branch block. And the other causes of that, of course, are pulmonary hypertension, pulmonary stenosis. Again, people who are wanting to be respiratory physicians, this can actually be a useful clinical tool for you as a bedside test. The other way you can have a wide split is instead of delaying pulmonary closure, you could make the aortic valve close a little bit earlier and have an even wider split. And it can close earlier if you have mitral regurgitation, because the mitral valve, if it's leaking, means that the ventricle empties earlier than you would expect. And therefore, aortic valve closure occurs even earlier because there's less blood there to go out, right? So it ends up in the atrium. So you can do that, and you can figure out that you can have a really wide split with MR. Now, what's happening here? What's happening here is a reversal of the physiology. In this patient, the pulmonary valve is closing first, and then the aortic valve is closing. And in this patient, when he takes a deep breath in, or she takes a deep breath in, they go, and you probably figured out what I'm about to tell you. This is reversed splitting of the second heart sound. Reverse splitting means that when you take a deep breath in, the split is narrow, and you breathe out and it's wide. That is a reversal of normal physiology. And that's reverse splitting. If you delay aortic valve closure, you can get reverse splitting. A tight aortic valve can typically do this, or delay in left ventricular conduction. Now, we've discussed a tight aortic valve, which can cause a crescendo decrescendo murmur. So now you already know that severe aortic stenosis, and it's a sign of severity, can give you reverse splitting of the second heart sound, as can left bundle branch block. You can also get it because ejection of blood is slow because it's a big, thick left ventricle. So hypertrophic obstructive cardiomyopathy can do this as well. And it is indeed a sign of severity. So if that's your reverse splitting, and you're always just doing this, At end inspiration, your hands come together, i.e. the aortic and pulmonary sounds are closer together. So in summary, wide split is caused by delayed pulmonary valve closure or earlier aortic valve closure, and reverse splitting is caused by delayed aortic valve closure. And that's splitting of the second heart sounds. I'm so sorry I overran. Just to round it off for the people who missed it, the PACES course we're running, where we have recruited effectively the best teachers we could find, the absolute best, and the best patients we can find. It's 1 day. It's at Bart's Heart Center. It will be run. It'll be run in a nice central London location. If you want to come for some quality teaching, do come to it. You'll find the course on those QR codes, and that Telegram channel. Please do join it. There will be free resources for PACES, regardless of whether you come to the course or not. Just join it. And you can have free resources for PACES. If for any reason you come to the course, which is aimed at neurology in station 5, and you feel and you find that on the day you fail either of those stations, touch wood, it won't happen. But if you do, this course will be free to reattend for you. If you come to the course, you will be paired up with one other person, which could be your friend that you come with, and no more than that. 2 of you at a bedside. Each bedside will have a patient. Each patient will have a senior registrar or a consultant teaching you, and that's it. You won't have to wait for them to come to you. They will be with the patient all day. So I do hope you'll come and take advantage of these this discount code, which drops 20% off the price tag. This code expires on the 30th of September, or if once it's used 30 times. I do hope you'll take the opportunity. I'm going to be doing some more webinars, me, my colleagues. If you have ideas for things you'd like to learn or specific topics you'd like covered, do feel free to email us, and I can see what I can do about sourcing them. Not every webinar will be done by me. You'll have better speakers than that. You don't have to look at my face the entire time, I swear to Christ. But I do hope you'll come back and get some use out of it. Please do tell people about this course. It's a passion project for us. We want this to be the best PACES course in London, and I'm very confident it will be. And I'm determined to deliver something really special for you guys. Thank you for taking the time, guys. I'm here to answer questions. I will open the Q&A now and see what I can do about that. I can't see the slides. Someone said I have resolved that, hopefully. I can't hear the murmur sound, sorry. Oh, okay, I have just put it through speakers. I hope you can. Oh, I hope you could. Otherwise, my imitation of the sound, I hope, was helpful. And the final question, how do you listen to the heart sound and ask the patient to hold their breath if they are breathless? You ask the patient very politely, are you able to hold your breath for a second? Is that okay? If not, then you obviously don't do that. You know, I mean, here you just have to be a bit practical. If it's just not feasible, the examiner will just stop you. You know, if it's even possible to do it, you do it. Because to be honest, this is something I didn't mention, but when you ask them to hold their breath, the murmur exaggeration, the pressures, it only lasts for 1 or 2 seconds before it normalizes. So when you're asking them to hold breath, it can't be 5, 6, 7 seconds. That's pointless. It should be no more than 2 seconds. 2 seconds is a surprisingly long time. Look, that's 2 seconds. So that is all the time you will hear the exaggeration of the sound of the murmur. After that, the pressures equalize and the exaggeration of the sound is gone. So it is no more than 2 seconds. And most people, even breathless people, up to 2 seconds of breath holding should be feasible. If it's not, then it probably shouldn't be coming to PACES, I would have thought, but I can't control every exam center. I'm just going to stop sharing just so I can see more of the screen. I hope this was helpful. Yeah, are there any other questions? I'm very, very happy to take questions. If you do have questions, put them on. You know, they can be anonymous. I don't need to see who's asking me questions, etc. Otherwise, please feel free to message me any way you can, or want to, if you want to, the 18 people who are left. But otherwise, it's finishing. Thank you for your time, guys. If you are typing a question, I'll wait for you. I seriously will. If you want. Let me just wait until the very last person disappears. Any resources to recommend to understand the pathophysiology for abnormal pulse and heart sound? You know, the thing is, I've learned about physiology and murmurs and things like that from so many random resources over the years. it's not one book or one teacher even that taught me. It was bedside. It was lots of echo training in my cardiology. It was lots and lots of resources. A single resource. I mean, Helio is a good resource, HEALIO. There's a website called Cardiovascular Physiology, CV Physiology, I think it's called. I remember when I was in MRCP, I found those really helpful. You won't get all the information I said to you on here because honestly, it's been gleaned over the years from so many resources. And I've just kind of, I mean, that's what happens when you've been in the game long enough. It's just you learn from people who are much better than you, and you take bits and pieces from each of them and develop like a little portfolio in your head. But those are the two that spring to mind. Helio is pretty good. I think it might even be a private resource from a company, but it's pretty decent, to be honest. And they're not pushing any particular agenda. And CV Physiology, I think, is the other one. They're both pretty good. Okay. Do you have any other questions, guys? Anyone else here? There's 2 people still here. I won't name check you, but I'm waiting to see if you're going to type a question or you've just logged into this, left it on record and walked away, which is cheeky, but it's doable as well. I think I'll sign out now. Anyway, it was such a pleasure. This has been so much fun. Murmurs are always fun, as I'm sure everyone here agrees. Here we go. There's another question. Why do we get different murmur in ASD? Why do we get a different murmur in ASD? That's a bit broad. What do you mean? Why do you get a mid-diastolic murmur? Because if that's what you mean, all right, I'll address the 2 possible variations of that question. In ASD, you can get a mid-diastolic murmur and you get fixed splitting of the second heart cell. The fixed splitting is the easy bit because we get taught that in medical school. So fixed splitting of the second heart cell is happening because you've got this hole in the atrial septum. And when you take a deep breath in or out, it doesn't matter. The pressures are equalized by that hole. But what you're getting is a fixed wide split of the, not just fixed splitting full stop, it's fixed wide splitting of the second heart cell. And the reason it's wide is because you get increased pulmonary flow and the pulmonary valve closure is permanently delayed. And that actually relates to the second part of the question that you could be asking potentially, which is why do you get a mid-diastolic murmur in ASD? Not always, but often. And the reason you get a mid-diastolic murmur is because this is a diastolic leak from left atrium to right atrium. Because it's a diastolic leak, that's when you get the turbulent flow, and that's why it's a diastolic murmur. Why do you get a loud S2 in MR? Ooh, loud S2 in MR. That's an interesting one. Let me just think. Is that what happens? So in MR, you tend to get a quiet S1, which is the opposite of mitral stenosis. A loud S2, I don't think you get a loud second heart sound in mitral regurg. At least you shouldn't be, that I can see. The reason for having a loud S2 means that the aortic valve is slamming shut louder than normal. You can get an earlier S2. You certainly can get an earlier aortic closure. I should say an earlier A2, an earlier aortic component of the second second heart sound. Whether it sounds loud is a little bit debatable. The reason it's earlier is because your mitral, because your left ventricle is emptying earlier. So I think if you're talking from the splitting point perspective, it's an earlier S2, not a louder S2, just to be clear. Okay, guys, I think we should leave it there. You can find me, Jason, Katie. I am going to name check you. If you can just email me or send this to me on Twitter, and I can take a better look if you just let us know. I hope that was helpful. Thank you for your talk. I've always enjoyed your sessions since medical school. Why would you make me feel so old? You're hurting my feelings there. But thank you. That's very, very, very kind. It's good to also know that someone I've taught before has come back for more, which means you clearly are a glutton for punishment. All right. Well, if you're still a glutton, then please keep coming back, and I'll be delighted to keep teaching. Thank you so much, guys. I gotta run. Bye-bye.
Bye-bye. Take care.